Welcome, everyone. Welcome to the Mental Health KC um, webinar. We're so excited to have you guys here today. Wanted to give you a little information about Mental Health KC and, in particular, Metro Council. Metro Council is the organization that hosts these webinars on the second and fourth Thursday of the month. Welcome, everyone. I'm Jamie. I'm with Metro Council. Thank you all so much for joining us today. Before we begin our webinar, just a couple things for you to know. We are using Zoom webinar. So because of that, you're only able to see the presenter, not yourself. But you can communicate through the chat and through the Q&A, and we really hope that you do communicate that way. We're going to try to be as interactive as possible. The certificate of attendance will be available at the end of the webinar today. We also ask, please, that you don't record the session. We're actually recording it for you, and that you do not take screenshots or use any sort of note taking to take the notes uh, for you. If there is a reason why you need that, just let us know. That's okay. We know it can be used for accessibility, and that's perfectly okay. But if someone is using note taking instead of being here, we ask that people are actually present. So with that, I'm going to tell you a little bit about Metro Council. So Metro Council is the organization that hosts these webinars on the second and fourth Thursday of the month from 12 to 1 for free. And we are collaborative of community mental health centers and other organizations that focus on behavioral health for the community. And the focus of Metro Council is to give information, education, training for individuals throughout the whole Kansas City metro community. Metro Council consists of University Health Behavioral Health, SWOBE Health, Rediscover Mental Health, Comprehensive Mental Health, Beacon Mental Health, Wyandotte Behavioral Network, Johnson County Mental Health Center, uh, Mental Health America of the Heartland, Center for Behavioral Medicine, and um, and and couple quick announcements. We do have save a couple dates, please. Mental Health KC conference will be um, May 28th and 29th. This year it's a Thursday, Friday. We're going to be having it at Johnson County Community College. I know it feels like forever away, but it will be here before we know it. But wanted to also let you guys know about something really exciting happening much sooner. And that is our fall symposium. It's October 28th at Mid-Continent Public Library, Red Bridge Branch, which is a great central location for the whole metro. And the fall symposium is going to be focused on ethics in a social media era. So we really hope that you guys can come to it. And with that, I am going to put it in the chat so that everyone can see our amazing fall symposium that's coming up, and hopefully you guys can register for it. So just again, a couple quick announcements. And with that, I am so excited to introduce Nate. Um, so um, Nate Hayward is just a little bit about Nate. Nate has the privilege of supervising the first episode Psychosis team for University Health in the heart of downtown Kansas City. Nate's team is made up of a medical provider, team nurse, and 4 case managers who collaborate to provide service for people within their first 2 to 3 years of a psychotic episode. Nate and his team have been trained in recovery-oriented cognitive therapy, CTR, Navigate model, and the CBTP. This interdisciplinary team works to provide clients with education on their diagnosis, family support, housing, medication management, employment assistance, education assistance, and engaging our clients in adaptive activities. Nate is passionate about the first episode psychosis population and enjoys the opportunity to learn with others about the best ways to support the clients he serves. So quick little thing, we always say this for all of our webinars, quick little disclaimer, that the uh, the views and opinions presented are those of the speaker, don't necessarily represent the opinions of Metro Council, but I have full confidence in Nate. Nate will do a fantastic job. So with that, I'm going to turn it over to Nate.
Right, awesome. Like she said, my name is Nate Hayward, and I get the privilege of supervising the first episode Psychosis team at University Health. I think the goal of today, honestly, is just to destigmatize psychoses. And really, I think we do that the best by like having a better understanding of it and then kind of drawing connections. And so if you are able to take one thing away from today, I really hope it's that. The other thing I would say is that's like kind of working in this field is like a passion of mine. And so I think as we like kind of talk, what I really want to do today is, although we can't have people like pop back and forth on Zoom, I really would encourage you guys, if you can, to be on the chat and just kind of like communicate throughout. I think I understand as a therapist that expectations are kind of everything. And so I think even as we kind of set expectations for what we're doing today, I want to show value. And so I think the more that you guys can just kind of share like, what you're looking forward to, what you're here to kind of learn, I think the better we can kind of maybe hopefully get to some of those things, especially like you're giving up your lunch hour to be on this. And I'm giving up my lunch hour to talk to about it. Let's make it like actually valuable and worthwhile. Um, so that being said, so with that being said, that's the first question I want to know is like, why are you here today? So if you can hop on the chat and just kind of share like when you saw that the presentation was called Understanding Psychoses and the Importance of Early Psychosis, Early Intervention. Why did you join? Why did you sign up for this? What interested you about it? Why are you here? So if you can fire those off in the chat, and then Jamie, if you can just kind of read off a few of those, that'd be great.
Definitely. So wanting to hear about current practice models and patterns with psychosis, gaining more clinical skills and knowledge. I hope to help someone. I'm a social work student and don't know much about it. Gaining knowledge. Let's see. Improve my knowledge, feel more comfortable with my understanding, to be more informed. Want to learn more about the topic. I thought it'd be interesting. Checking my bias. Just need a reminder. Work in the school system. I need a reminder and identify and better identify to serve my students, be more informed, identify insight where somebody works in the jail. So it's good to understand the early stages of psychosis, possible drug-induced psychosis, question mark. Always been a topic of interest to me and want to gain more understanding and insight, especially when it co-occurs with multiple mental health diagnoses. With my knowledge of psychosis and internal biases to better understand how to early intervene, to become more informed for their and my coworkers' safety. I work with people who are court ordered uh, for substance use disorder. I work with young adults who have experienced trauma, and I like to understand the signs of psychosis better. Drugs and psychosis.
So I'll keep moving ahead here, but I think thanks for participating in the chat. And what I would say is I really appreciate you guys being on here. It sounds like we have people who work firsthand. We have other people who maybe have relations. We have other people who maybe just want to further their knowledge. And so, kind of the goal for today and what you can expect is what we're going to do first is we're going to talk about what is psychosis. I have a little video I'll show, and at the end, I'll kind of actually take that the website that provides that video and give it to you as a resource. Secondly, I want to focus on like why early intervention, like why is my team a thing, and what is the importance, of early intervention. Then I'm going to tell you a little bit about what we do, just kind of some basic intervention things that we do. I can kind of maybe try to pepper in there maybe a few little recommendations, and then fourth is going to be what can you do as someone who maybe is interfacing or interacting with this, maybe just some basic tips. And then lastly, I am just going to talk a little bit about resources that I feel like are good, and that you can kind of steer families towards or yourself towards, or if you're in the school settings, maybe just educating people more. Because like I said, like I think destigmatization really happens when people have a better understanding. It's really hard to fear something that you kind of know and are connected to. So I'm going to show that video now. And then after that, we'll kind of break down a little bit more in depth what is psychosis.
Having trouble sleeping at night and is sluggish. Charlie was an outgoing, busy high schooler, but lately he hasn't been acting like himself. Charlie is having trouble sleeping at night and is sluggish when he is awake. Simple daily tasks are getting harder to manage. Charlie has been very quiet and tense. When he does talk, he's not making a lot of sense to others. His friends worry something is wrong, but are having trouble knowing what to say. He confided in his best friend that when he goes out, he worries that people want to hurt him. And sometimes he hears voices of people talking when no one is around. Charlie is experiencing first episode psychosis. So, what exactly is psychosis? Psychosis is different for everyone, but can be described as experiences or symptoms that interfere with the way we process information, causing us to feel disconnected from reality, which can be distressing. Charlie has been withdrawing socially. He thinks that others are out to hurt him. He hears voices others don't, has less expression of emotion. He is experiencing changes in his sleep patterns, self care, and motivation, and his speech is jumbled and hard to follow. Additional signs of psychosis can include thinking others can control your thoughts or actions against your will, thinking that things around you have special meanings just for you, thinking you have a special power or ability, or believing you are a famous person, or seeing or smelling things that others don't. Sometimes these symptoms come on quickly and last for a short time, but they can stick around for longer or go away and come back later. We're still not sure why people experience psychosis. It's not anyone's fault, and there can be different reasons or causes. If you or someone you love is experiencing psychosis, it can be a scary time and hard to know where to turn or what to do. It's important to reach out to a mental health professional to help sort through what is happening. Connecting to a team of supportive and specially experienced people at a Pennsylvania First Episode Psychosis (FEP) center can help. Our FEP Center teams will work with you or your loved one to coordinate a personalized treatment plan involving a variety of services, and the support team will be by you or your loved one's side during the entire recovery journey. It is important to remember that while things may feel hard, you are not alone. Support is available, and getting help early offers the best path to getting back on track. Connect with a Pennsylvania FEP center near you.
So when we're talking about first episode psychosis, really what we're talking about is a couple different things. So Psychosis is usually going to be more associated with the positive symptoms of schizophrenia. So just because someone has, and I think maybe a important thing to note is psychosis like is much more common than people even talk about or would think. It's just simply like put like hearing things, seeing things, um, experiencing things that other people around you aren't experiencing. The causes for this can be like multiple. It can be drug induced. It could be trauma related. It could be, lack of sleep. So there's a lot of people who experience psychoses in their lifetime. I think what makes our program different is when we're talking about a first episode of psychoses, really what we're like looking for is an actual full-on psychotic episode. So some of the things that we're going to look for is like positive symptoms. So that's going to be like hallucination. So that's going to be seeing things, right? That's going to be smelling things, tasting things, hearing things that other people don't hear. It could be disorganized thoughts. So it could be, feeling like having trouble kind of, like especially for like some of our younger kids in high school or kids that experience this in college, it can be, just like distracted thinking. It's kind of like not just zoning out, but it's kind of like your thoughts aren't really piecing together all the way. It can be delusion, so it can be feelings of persecution or paranoia, feeling like people are out to get you, or it can be grandiose delusions where you're feeling like you're a bigger part of a larger whole and you're a very important cog in these things. So positive symptoms are going to be the things that are added to like a traditional like kind of human experience. So those are going to be, like I said, like the additions. A lot of times what this looks like in reality, and I know a lot of you said, you work with this to some degree and maybe some things to look out for. Before someone has a full psychotic break, a lot of times what I'll see is like prodromal symptoms. So those are kind of symptoms early on that maybe would have hinted that like a episode is kind of imminent. So one of the most common ones is just going to be tied to delusion. So it would be, someone starting to have maybe like odd thinkings. So maybe someone like maybe occasionally is a churchgoer or is slightly religious, and then all of a sudden they become very religious and they are talking about religion, but kind of in a fanatical way that doesn't really fit with, who you know them to traditionally be, or it could be them like not hanging out with people as much and kind of seeming to withdraw from people. If you notice, this can be kind of hard to predict because like those also would be associated with like depression and a lot of other things, or it can just be like, people have bad weeks. So it's not always something that you can just like catch easily. The other thing that's going to be like really present, especially for people who maybe are going to have that schizophrenia diagnosis, are going to be these negative symptoms. So these are the things that should be there but aren't and are missing. So lack of motivation, and I think I think people get this confused sometimes. So when I talk about lack of motivation, I think if it really is like within a first episode, and especially if like the diagnosis in the future is going to be schizophrenia, really what you're talking about is you're talking about people who just completely, it's kind of like like when I kind of maybe have laid around all day and I'm like, okay, I need to get up and do something, that part is missing. So like that kind of those brain neurons, like that firing, that chemical reaction that kind of gets you up and doing things, it's like an absence of that. And so it's not just like someone being lazy, it's really the opposite of that. And that's really a common misconception. Some other things are going to be, more isolated behaviors, just like stopping, spending time with people, things like that. One of the ones that's really challenging for us is going to be just this lack of ability to perceive their own symptoms. Sometimes when you lose your ability to kind of, know what is reality and what is not reality, it's going to be really hard for you to even realize that like something's going on with you. And so that can make it harder to like really just, start working in services. And then lastly, and I think like a key factor is going to be, lack of emotion, lack of expression, like it's going to feel flat. So it's going to be just like lack of responsiveness a lot of times. Um, but kind of, I think the even more important part here is the stigma associated with psychoses. So in the chat, if you could throw out some just common things like when you hear the word psychoses, or when other people around you maybe find out you're working with psychoses, what are like some of the common stigma things you hear? And if Jamie, you can kind of read them out as they pop them in the chat.
Mania, violent, that the person's crazy, violent, hurting others, people think it makes them violent. A person with psychosis is crazy, unable to understand reality, crazy, fear, misunderstanding, dangerous, crazy, can't be helped. They will always be that way and can't get better, unstable, unfit parent, on drugs. That's what we have thus far.
So like as like you think of those things, like none of those are like positive associations. And so I think like even if you think of kind of bigger things in the media, if there's kind of like associations with like mass shootings or serial killers, like it's kind of always linked as like, oh, they were experiencing mental health problems, and then they'll kind of say like psychoses, or they'll say schizophrenia, or they'll throw out things like that um, that really make kind of give it a bad rap. And so I think a lot of times what we're really dealing with, and kind of what I want us to focus on for a second in the chat is um, like when I meet individuals who are having a first episode, it's typically like in an inpatient setting, or like because a family member or a friend was concerned and somehow got them in front of me. Um, but I think if you kind of just think of it like more logically, like what would you do if um like suddenly uh you would have these really kind of like vivid experiences, like these really like I think that one of the misconceptions about hearing things or seeing things is that it's always like negative. But like what if the things that you were hearing and seeing were like really positive and affirming, and made you feel special and unique, and then someone's telling you that those things aren't true? Like how would you handle that? How would you feel? What would you do? So maybe throw in the chat like if that were you, if you maybe felt like, let's say you felt like you had a direct connection to God, and you were like gonna be able to like help these other people, like how would you feel, or what would you do when like the people that are closest to you are telling you that's not true? What would your reactions be?
Said sad, angry, confused, feel attacked, think that the person's jealous of me, not believe them, surprised, defensive. I would be upset, become distrusting. I would hide it. Distrust, angry, invalidated. I would feel scared and confused, feel defensive and confused, belittled.
Yeah. And so I
Yeah.
think a lot of the things you guys are putting in there are like absolutely true. I think when we think about like what would you do if suddenly people were telling you you couldn't trust your thoughts anymore? Like that's just such a tough thing to deal with. I think the thing that I've noticed the most as I meet different people and experience these different things is I think that people, when they're dealing with a lot of loss, they're grieving kind of this idea of, being able to trust their own thoughts. But also like a lot of them, will just kind of remove themselves from the world around them because it becomes a little scarier. They don't always know what's real and what's not real. And so what we're talking about is kind of, that loss of self. I think like my self-identity is so tied to my thoughts, to like how I think, the way I think. But I think, really what we're talking about is loneliness, right? Like the feeling that no one understands me, that no one gets me, that no one else experiences this. And so a lot of times, if you're talking about first episode psychosis and you're, trying to define it for someone else, like simply put, it would just be like someone experiencing, like unreality. Someone's experiencing, like something kind of outside of themselves. So it'd be hearing things, seeing things, you know, uh, feelings of importance, whatever. That's kind of first episode psychosis in a nutshell. But I think like if we're talking about like the stigma associated with it, I think what I found working with this population is um, I found a lot of people who are just these really sweet kids who feel really misunderstood and feel really alone. And so when we're talking about first episode psychoses, I think that's kind of the first key factor is like if we're trying to talk to other people about this, I think so often when we label people crazy or label people, kind of all of the things that were thrown out in the chat earlier, it doesn't really lead to a lot of like curiosity or, wanting to understand what's going on with them. Instead, it's just kind of like a label that's given to them that, puts them in a box. And so, kind of what like the importance of early intervention services are really kind of spelled out in this next slide. So the National Council for Behavioral Health did some studies and found that you know uh, schizophrenia, psychotic episodes, all those things, number one, they can be really expensive. Like if you're thinking of hospitalizations, incarcerations, police interventions, destructions of property, all these things. Like it's definitely a cost to state and federal levels, but that's not really why it's important to me at all. The other thing is it's like more common than you would think. A lot of people experience us, some version of this at some point, especially in Missouri with like the legalization of, marijuana. There are impacts to that. Higher potency THC has been known to cause hallucinations, delusions, those other things. And so, we're seeing more people just from an observational standpoint end up in the ED for these things. So then the other thing is like if you're familiar with ACEs, adverse childhood experiences, definitely this would fall under trauma, not being able to trust your thoughts, those things. It can feel like a lot. And like I said, you're dealing with a lot of loss. And so the rate of attempted suicide with this population is higher. And so the other thing that's challenging is the duration of untreated psychoses. So if you look at the top middle little red circle, 74 weeks after the onset of illness is the typical kind of intervention for psychosis services. And so really what we're talking about here and the importance of early intervention is if you're thinking about like the nature of psychosis and the nature of like someone experiencing a psychotic episode, if there's not early intervention, if there's not treatment, typically what happens is that's a lot of extra time with them being alone by themselves, kind of with like those thoughts of, maybe hearing things, seeing things, or just having kind of odd ways of thinking, feeling like people are out to get them, whatever. The longer that you kind of stay in that, it kind of makes sense. The harder it would be to kind of get out because you don't really have anyone or anything in your face, like challenging kind of those beliefs. And so really early intervention services and kind of why we're a team, why this is important is the quicker that we can get to people and start to kind of challenge some of those thoughts, ideas, whatever else, the higher the treatment outcomes are. So that's when we see, people getting employed again. That's when we see people returning to school and finishing school. that's when we kind of see a lot of like maybe the things associated with schizophrenia or psychoses or bipolar disorder with psychotic features or major depressive with psychotic features. It's kind of like the earlier we intervene with those things, the better the results. And so that's kind of what me and my team does. So I wanted to talk a little bit about a day in the life of our program and kind of what I'm typically doing. So I'm usually showing up in like inpatient settings. I'll usually get a
Nate,
referral. Oh, yep.
we have a quick question.
Yeah, go
So
ahead.
what is a treatment plan for psychosis?
Sorry, can you say that one more time?
What is a treatment plan for psychosis?
Treatment plan for psychoses. So um, kind of like to tie that into day in the life, I think a lot of what we're trying to do is we're trying to get people who've been like maybe locked in their homes with like out spending time with anyone. Um, maybe they've been like on the legal radar for like a lot of times it's not like violent crimes. Typically it's like going into a grocery store and like grabbing something or just doing odd things in public that get them picked up. So a lot of times what we're doing first is unfortunately a lot of their support systems feel pretty frustrated by the behaviors. And so a lot of times um, first we're just kind of focusing on that like Maslow's hierarchy of needs. So like let's say we meet a new person. A lot of times like if I can't find them, I can't really treat them. So like step one is typically like, do we have a place where we can see them, most often? So sometimes it's like trying to get them housing, but in the meantime, like let's say they're unhoused and they're kind of wandering the city, we try to find like a place where they can get food every day, and then we can kind of meet up with them and start like getting them housing. Um, Sometimes too, it's just like we have some people we partner with. We have like respites and some other things that can like start giving medication, because the other thing is if someone is like dealing with a lot of psychosis and has been in it for a minute, like that medication treatment is going to be super helpful. And so a lot of times we'll try to like get them immediately appointment with a psychiatrist and just start like trying to get some medication. Sometimes it's a long-acting injectable. Sometimes it's oral medications. And that's where the respite comes in, because respite is a place where they have like nurses on site that can provide medications. And then also kind of after we have like some medication regimen, or like we've kind of tackled one of those things, we're going to really kind of focus on like what's meaningful to the client, what do they like, what do they care about, and then we're kind of trying to take that thing that they care about, that excites them, and really like a lot of times if they have that flat affect, we're kind of looking for that thing that like kind of changes that a little bit. So, maybe it's like something simple like let's say it's just playing basketball in the community. A lot of times we're going to try to do that with them and then utilize that as a jump off point to be like, hey, like, wouldn't it be cool to have a membership at one of these places? How can we get like maybe a part-time job so that you could afford a membership here? How can we get you a pass through like a program to get you a membership here? And then we kind of work off of that. But I don't know exactly if that was their question, but that's kind of a typical like psychosis is going to be different for everyone. Some people are coming in with, a lot of um, symptoms. Some people are coming in with, a few symptoms. Some people have been, experiencing them for months. Some people have, been experiencing them for years. Typically my team, and for it to be considered first episode psychosis, that's going to be within their first 2 to 3 years of their first psychotic episode. So that's kind of like the point of it, is that that's kind of our little window of time where we're going to be the most effective with working with psychosis. So that's kind of a treatment plan. So um, a day in the life of our program is going to be like, a lot of times first I'm trying to find these people. So that's even where you guys come in, and when I'm going to talk about it in a second about what you can do, but a lot of times, like, if you're aware of someone who's experiencing first episode psychoses, if they're, within that first 2 to 3 years of experiencing it, a lot of times just getting them in front of us is kind of step one. Like, we're just trying to find them. So a lot of times it does unfortunately lead to them being hospitalized. And so a lot of times I'm going into the inpatient setting. What I'm doing in there, and kind of like, I think some people on the chat were asking about like how to work with this population. I think a lot of times, maybe they've been in the inpatient setting and no one's talked to them, or like the only way they've been talked to has kind of been talked down to. And so a lot of times uh, what I'm trying to do is just like get to know them a little bit. Like we said earlier, a lot of people are just feeling lonely and alone and scared and confused. And so a lot of times I just want to give them something familiar. I want to find out like, hey, like for like so many people, it's music. Music's such a great connector. And so like sometimes I meet them, I say, hey, just 5 seconds, tell me about your like what is your favorite thing, like what's your favorite musician, who's your favorite group. And then I don't just ask them about it, I like pull up my Spotify and I like play the song, and then I'm like asking them about, why is that important to them, why, like, how did they find this artist. I ask them to teach me about it. I think the more you can have them teach you something, the better. So that's kind of what I'm doing initially, is just we're trying to meet them, kind of assess and see if it's psychosis. Once again, what I'm using to assess is, do they have those positive symptoms? Do they have those negative symptoms? When did this occur? Is this within the last 2 to 3 years? Was there a change in baseline? So were they like a straight A student before, and then all of a sudden now like they can't even attend class anymore? Those are kind of some of the things we're looking for. But yeah, so once I assess them, either, whatever setting, typically then I'm calling my case manager on my team, or I'm calling therapist or whatever. I'm trying to give them a warm introduction and just kind of introduce them to the team. So this is my team. So in the back is Austin. He's our therapist. Julian, Michaela, Ruth, and Taylor are kind of in the middle. Those are our case managers. Stephen is our nurse, and then Aaron is our med provider. And so kind of what we're trying to do initially when we meet people is just the more that we can kind of just make a connection with them in some way, and then kind of figure out what they want. We usually tie it to like, okay, if we can get some medication going, and that's when we introduce them to Aaron, our med provider, and say, hey, like, I think this would help with your focus a little bit. Like, I know you want to get back into school. And then maybe it's like, well, we can't find you though, so can we get you some housing? And so that's where the case managers come into play. We kind of look for housing in the city. Sometimes we partner with our group homes at University Health, or sometimes we'll partner with outside group homes. We'll partner with like other housing options as well. If kind of like supportive living options. Sometimes we're just kind of trying to find a way to like get in there and like do something like meaningful. The other thing we do a lot of is we do groups. So the idea is, if you've been spending a lot of time by yourself, not really socializing, it just causes you to feel more alone, like we talked about earlier. And so really, if you're looking for things that I find very helpful, I mean, a lot of the people who are going to be in first episode psychoses, that's going to be, between the ages of 16 to like 24, is when we usually see those symptoms start to pop up. Kind of the best thing that you can do is kind of get them into like a setting that they would enjoy anyways. So like we do a basketball group, or we do like one group we do like working out together, so we like lift weights together. Another group, they play chess. That kind of helps like organize thoughts. One of them, they get to just kind of hang out and talk about their own experiences and what it's like to hear voices and things like that. So the idea with groups though is, if you've been spending a lot of time by yourself, you haven't really flexed those social muscles very much. And so we want to give them a safe place to do that. But most of our groups are actually done in the community. We want it to feel like our clients don't want to feel like clients. They just want to feel like a 20-year-old. And 20-year-olds hang out in the community. They go to coffee shops. They, go to fitness centers and work out with friends. And so really we're just trying to give them a creative environment where they can do those things and feel those things. And so a lot of times, that's kind of like if we're asking about a treatment plan earlier, all these things that I'm mentioning right now are going to feed into that, or, you know, be what I would recommend for anyone experiencing first episode psychosis. Is the more we can connect them with others, the more we can make them not feel alone. Like those are all going to go a long way. Which brings me to what can I do? A lot of times the things that you can do is, um, a lot of like the stigma that we talked about earlier is going to result in people not really wanting to share it, or not wanting to feel other, or different. And so a lot of times I think if I'm curious and I explore people's differences and I act interested in what they're saying, like the better. Sometimes this can be tricky because if someone's saying that they're God and they are gonna destroy the world or something, like it's hard to know what to say back to that. And so I think a lot of times, sometimes when it's like maybe coming from delusions, or they're hearing or seeing things, um what I want to do as a person like working with that person is more just kind of form a connection in some way. So maybe they're talking about a lot of things that aren't real, but they're real to them. And so sometimes it could even just be they're talking about that thing, and maybe I'm saying I'm trying to do something alongside them. So it might be the music thing. Sometimes it's throwing a ball back and forth. Something that just kind of connects them to like the real moment would be something that I would recommend. Things that I would avoid is shame, guilt, just anything that kind of leads to those lonely feelings. That's going to actually be like triggers for like psychoses. Those are going to be things that actually make it like harder for them to really interact with you. Um, but I think what I really have found, and we've found to be true as a team and working with this, is the things that matter to me are the things that matter to our clients as well. And so um, in the chat, I think maybe like when you're thinking of what you look forward to, like what gets you up out of bed, what gives you meaning and purpose, like what are some of those things that you guys have that, excite you?
My doggo, my spouse, my work, connection to other people, family, doing things I enjoy, family, nature, family, community, art, writing and creating art with friends, my work and writing interests, God, friends, community, family, doing things I enjoy, my family, spending time with family, doing things together, going to church, being with friends, my faith and my friends, family, friends, work, school, my dog, family, travel, my family.
So as you're like hearing those things and as you're writing those things, like that's you just hear like the similarities. I think it's the same for the clients we work with, or these people experiencing psychoses. They don't want to feel like someone who has psychoses. They want to feel like a 20-year-old who is helping others. I think even like why a bunch of us are probably in some form of helping profession is because it does give us meaning and purpose. It's fun and it fills us up to be able to like show up for someone else. And so I think a lot of times, what you can do if you are working with this population is finding that little thing that means a lot to them. And sometimes we have to start really small. So like, um, for some people, like in our program, they come in and they don't seem to have a lot of interest. They don't seem to have a lot of things they do enjoy. And so I think it's just kind of like being creative and curious on my part, and like presenting them opportunities. Maybe it's, taking them with me to like volunteer. And I think that's maybe the if you took one thing away and you're working with this population, I think a lot of it's doing with, not telling them to do. So it's going to be like a lot of our interventions, like after this, I'm going to go to fitness group. I'm not watching them lift weights. I'm lifting weights with them. Because if you think about it, if you're a 20-year-old and someone's just like watching you lift weights, that's kind of like weird. But if you're like doing it together, you're forming connection, and that connection is really going to drive a lot of the things that um, you know, kind of lead to those. So like once we're connecting, like once we're lifting the weights together, that's kind of what I'm shooting my shots with them and saying like, hey, like you did so good today. Like you put in so much effort. Like, what would that look like, at school if you like put in the same effort with your work? Like, what ways could you do that? That's kind of essentially what I would say. If I could give one tidbit about working with this population, the more you can make that solid connection. And what I'm really looking for as a clinician is, as I'm doing that intervention, a lot of my people are going to come in, like kind of flat or like not very interactive. They're going to kind of be to themselves. I want to kind of wait for that moment where they start like smiling a little bit more. I kind of joke with them and like they actually like laugh at the joke. And then that's when I know like, okay, I can actually talk to them about this deeper thing, because that means they're like actually interacting with me and they're not like in that kind of shut down mode, where they're maybe like distrusting of people, or they're like kind of looking out and view the world as scary. Now I've kind of like I've kind of challenged that a little bit with this intervention, right? Like, because in that moment, they're not feeling scared. They're just feeling heard and seen and, whatever else. So I would say, if you are working with this population, that's absolutely, like, if I could say one thing, partnering with and doing with, like, that's the number one thing. The other thing is, I appreciate you guys being on this today, because like more people need to know about this resource, and need the more referrals we get, the more people we can help. And so I do want to kind of say what a good referral looks like. And so just because someone has seen something once, it doesn't necessarily mean they're having a first episode of psychosis. Like we said earlier, it's going to be, hearing things, seeing things, and kind of like there's not another explanation for that. So some rule outs or some reasons I wouldn't maybe bring someone on the team would be, is this just is this drug induced, and is this like once the drugs are out of their system, does it go away? Or if it is drug induced, like maybe a good referral for me would be, they did the drugs, they're no longer doing the drugs, but the symptoms are still remaining. That's seeing things, hearing things, maybe some of that flat affect, whatever else. Typically, it's going to be within the ages of 16 to 25. That doesn't mean it doesn't happen earlier. It's just going to be a little less likely. And then really what we want to get is clients who are in their first episode. So that's going to be within that first 2 to 3 years of a first episode. So that's going to be the first time they had a full like psychotic break. So if someone's like 5 or 6 or 7 years in, they're probably not as good of a referral to a first episode psychosis team, but that doesn't mean that they shouldn't get help and resources. And so even if you do have someone like that, still referring, my email is down at the bottom of this. And so shooting me an email, just kind of telling me, I'd rather, hear about them and be able to pass them along to someone than not hear about it and us, have no intervention for someone experiencing these things. So lastly, resources. So that website I showed at the beginning, that heads up, it has a ton of resources and it's really cool. Some of our clients are Spanish speaking, and you have the ability to click on it and change the website to like different languages, which is really cool. It has supports for families. So it has like education for family. It has education for like schools and school resources. It has education for like the individual who's experiencing it or the provider experiencing it. So it's a great website out of Pennsylvania. Honestly, the more we have like things like this and resources we can give, the better. Another one that I really like, if you're if this is just an area of interest, there is a podcast called Inside Schizophrenia, and it's put on by a woman named Rachel Starr Withers, and she is someone experiencing schizophrenia and psychosis. And her co-host is someone that experiences psychosis and was diagnosed with bipolar disorder. And so I think it's a really helpful website, or sorry, a really helpful podcast because it is coming from people who actually experience psychoses. And I think those resources are always kind of the best. So with that being said, I wanted to kind of open it up now for some questions in the chat. So
we had a couple questions before you even said that. So organically, is there a neurochemical malfunction in the brain?
So sorry, is the question like kind of like what, like kind of why this occurs? Is that kind
I
of
think so.
okay? So I can say that like in terms of when I meet with families and they have the question of why, I think we know that there's genetic precursors. So typically we'll find that people who have a relative that's diagnosed with schizophrenia, or someone in their kind of family lineage, that can be definitely there. I think they at this point do know that there's like some misfiring of neurons, or there is issues with those things, but I honestly like can't speak to that specific, because I think what I've experienced is like I don't think I have a good answer for exactly why this is happening. And sometimes the why isn't that helpful, because especially if it is going to be a schizophrenia diagnosis, um, it's going to be like a lot of times those clients are going to have to find out, what means something to them, and then kind of how to hack some of these symptoms, how to find their ways to kind of like move around it. So I do appreciate the question, and I do think that's a piece, but I don't think it's the whole piece. And I think if I acted like I knew that for sure, it just wouldn't be honest, because I don't think that's the only factor. I honestly, I just don't. I haven't seen any research that definitively says it's this. There's a lot of different factors that go into it. Let's hear a few more.
Okay, so are your groups only open to university health patients? And are these groups reoccurring weekly, or do they change? Is there a flyer or schedule we can give?
Yeah, so good question. So yeah, they are only open to our clients, just because if we just had like everyone coming to them, that probably wouldn't be a good idea on my part, because it kind of kills the like confidentiality of it. I would say like when we're out in these communities, people don't know our clients have psychoses. They just think they're like teenagers and like early adults playing basketball. So while that's maybe not like a resource that's open to you, I think if we're kind of asking ourselves what we can do, I think that's like a key factor. I think the more that we had these kind of opportunities or groups, like if it wasn't just us, doing that, and it's other people, I think, and it can start small. Some of our groups, like the first time we had them, like two people that showed up, and playing basketball with two people is like, kind of awkward. So sometimes it's like you starting it and then, getting more clients to show up over time. Let's get a couple others.
Okay. Do clients have to have insurance?
Uh, yes, but that's not like that's actually one of kind of someone asked about the treatment plan earlier. A lot of times we're trying to get people set up with that, like if they come in the door, because maybe they had all those things and they, became unhoused, and a lot of, I don't know, even I need help getting my insurance set up sometimes. So I think especially if you're, a little disorganized, it can be really sucky. So they don't have to have insurance. Like we can help them out with those things. It's something that we're usually going to work on kind of within the first week of meeting with them.
And then What's the name of the podcast?
Yeah, the podcast is called Inside Schizophrenia. Let's see. Do the thing where I like show my phone to the screen. So I think it's on like all the major podcast carriers. Looks like that. So Inside Schizophrenia. And like I said, this is Rachel Starr Withers, but she usually has a bunch of different people who different experts in the field on. And then she kind of always shares from her experience, which I think is extremely valuable because it's not me telling someone else about their psychosis, but it's someone with psychosis, really talking about it. And then
Okay,
I'll throw my email in the chat. I see a couple people asking about that.
so we have a few more questions. Do you classify someone as still being in psychosis if their symptoms are managed?
So I'd probably ask a few more questions if we could, and have a dialogue back and forth. I think I'd want to know what you meant by that. So, like, for example, I think psychosis, like, especially if they're like being referred to my team, it's not going to be something that we're trying to necessarily get rid of, because a lot of the people, so like the major diagnoses that my team is going to work with is going to be schizophrenia, schizophreniform, schizoaffective, major depressive with psychotic features, bipolar with psychotic features. And so a lot of times, like in those settings, like let's take bipolar disorder with psychotic features, for instance. Maybe those won't always be there and be present. So they might not be hearing things and seeing things all the time. It might come and go, especially with like manic symptoms, versus like someone who has a diagnosis of schizophrenia, like is kind of going to be there all the time. And I don't think it's necessarily going to go away. Medication can maybe like quiet that down or give them a little bit of focus, but typically they always have like some version of something going on in the background. And so sometimes it's like realizing, maybe how to like turn those voices down and turn what they care about up a little bit more. Sometimes it's like even like it'd be kind of similar to like having a major depressive client, go on walks every day. They have to find ways to kind of get their, manage their own symptoms. So I don't know if that answers the question completely, but yeah, like I think for different diagnoses, like it maybe is, there are people who, especially if it's just substance induced and they stopped using substances, and they don't experience symptoms anymore, then yeah, they don't have psychoses anymore. But there are a lot of times, like what we're looking for and what we're talking about in these instances are people who are going to continue experiencing those.
So it says like someone that's hearing or seeing things, but they're aware it's not real and able to function.
Mm-hmm.
Okay, next question. What's the significance of 16 to 25 as it pertains to psychosis? And the second
So yeah,
question
thank you for asking.
is it
So 16 to 25 is just when we see like the onset of like first episode psychosis a lot of times. So that's going to be when we start to actually see people like hearing, seeing, experiencing those delusions. And it's just kind of the age of onset. So a lot of times there's going to be like kind of a major life stressor. And if you think about those times, like you're either starting college or you're like, kind of having to decide what you want to do with your life. So I don't, once again, I don't know the why of all of it. Why does it tend to always occur around that time? I'm not sure. One thing I will say is uh, drug use definitely seems to maybe lead to earlier onset. So if someone's using at 15 or 16 and they have a genetic predisposition towards like schizophrenia or bipolar disorder, like sometimes we'll see that trigger a first episode.
okay? So, do most services require clients to be clean to participate in programming? Is drug testing a part of intake or ongoing participation?
So we don't require that because we I would say like especially marijuana use is like a very normal thing, especially for people in Missouri, because like a lot of our clients are over the age, like they can just get it at like a store or something. So it's not like a requirement. I would say like kind of like most things, we're kind of asking ourselves like, what is the like actual thing that's like impacting the client the most? So like, is it the drug use, and is this more of a drug use disorder, and then psychosis is going on in the background, or is psychosis actually the main thing? And that honestly can be hard because it can be really chicken or the egg scenario where maybe they're having psychosis symptoms, and so the drug use, they're kind of self-medicating to kind of maybe turn those voices down. So yeah, we do have co-occurring people on the team.
And then another question, is it more common in male-born or female-born individuals?
I would say males, just because it's probably more obvious, but what I'm realizing is us as clinicians are kind of just bad at diagnosing females. I feel like sometimes they're maybe a little bit more socially conscious, a little bit more like emotional control or masking, and so sometimes we just miss it. So yeah, a lot a lot of times. I don't know. I'd say like research wise, I think they've typically said it was more male, but I think from experience, I don't know if that's completely true. I think we just kind of miss it more.
Okay, guys. Any other questions? Oh, a couple people want your email address again.
I think I popped it in the chat, but it might have got buried.
Okay, any last questions? Oh, have you heard of a symptom called echoing?
I have not, but now I'm very interested in in hearing that symptom. So yeah, I will probably go look that up right after I get off of this.
Okay, guys. Well, thank you all so much. Thank you so much to Nate. Certificate of attendance is in the chat. And I just want to thank you all again so much for being here. Thank you again to Nate for being here. And we hope everybody has a wonderful rest of your day. Just a reminder again, our fall symposium is the end of this month, October 28th. And we hope to see you there. And have a wonderful day. If anybody needs the info again for the fall symposium, it's also in the chat. Again, certificate of attendance is in the chat. And we'll stay on for just a couple more minutes just in case people have some last minute questions.
Right. I'm actually gonna hop
Okay,
off
guys.
because I'm heading to one of those groups that I talked about. So
Thank you.
thanks.